Well, greetings everyone, and welcome to the EKG case for the week of December 10th, 2012. And hope everyone is enjoying the onset of the holiday season. This was a holiday gift that was sent to me by a former graduate from our program, Dr. Sean Fox, who's now a superstar faculty member at Carolinas Medical Center. Sean was trained in both emergency medicine and pediatrics and is double boarded. And this is a great case because this is completely relevant to adults or kids, and you'll see why that is in just a moment. So Sean sent me this case. There was a patient that had presented to their emergency department after apparently having a seizure. And the reason I put seizure in quotes here is because this patient had no prior history of seizures. So presumably this is a first-time seizure. And whenever a patient presents with what people say is a seizure, you need to ask them, what actually did you see? Seizure is a medical diagnosis. You need to ask those people, what do they see? When lay people see a person fall to the ground and shake, all of them think the person's having a seizure. And in reality, we know that there's a lot of things that fall and shake besides just seizures. So that's why I put it there in quotes. You need to get to the details about what actually happened. Well, anyway, perhaps there's no exact details yet. So I would ask you, what is the workup when somebody comes in after having an apparent fall and shake type of episode? Well, usually we're sending off a bunch of labs. A CBC, a Chem 50, a Chem 100 if you have it, a urinalysis. It's probably a guy, but just send off a pregnancy test, SED rate, CRP, ANA. You're, of course, going to get a CAT scan of the head, maybe an MRA, MRI, MRV. Well, all of it's kind of silly because the one test that you need to start with, I'm being facetious, by the way. We don't actually do all of that stuff. But one thing that we do with a first-time apparent fall and shake episode is to get a 12-lead EKG. It's absolutely critical you do that in patients that have a first-time seizure, whether they are an adult or a pediatric patient. And what's the reason that you need to do that? Well, the reason that you need to get that EKG in these first-time apparent seizures is because, like we said earlier, not everything that falls and shakes is a seizure. It's possible that the patient had an arrhythmia, they hypoperfused the brain, they fell to the ground, and actually had syncope with maybe some myoclonic jerks, or maybe they really did have a seizure, but it was induced by ischemia to the brain from an arrhythmia. So if the patient has not had a prior workup for seizures and not a proven EEG showing a seizure focus in the brain, get that 12-lead EKG on that patient. And that's exactly what Sean did. And here is the 12-lead EKG. So let's go through this, and we're going to focus a little bit more on the rhythm here. Hopefully, as you look at the rhythm strips, and we always start with V1 because that's our money lead, but actually you see some abnormalities here in lead V2 as well. What you probably notice is that there are blips in here that are not being conducted, right? So those are presumably P waves that are not being conducted. So that means that we're looking at some type of AV block, not first-degree block, but is this Mobitz 1, or is this Mobitz 2, or is this third-degree heart block? Well, whenever you're debating Mobitz 1 versus Mobitz 2 versus third degree, where do you look for the answer? Of course, you look in the PR interval. So actually, before we even look at the PR intervals, let's just prove that this is truly a heart block of some type. You see blips that are not being conducted, and so, well, maybe there might be some that are buried in some of these QRS complexes. I'm not really sure. What I like to do when there's some P waves that are very obvious and some P waves that are kind of mushed into T waves or maybe buried within QRS complexes is I like to look at the rhythm strip and find some area on that rhythm strip where I clearly see two very, very distinct P waves, and that's where I start mapping out that atrial rate. So if you look on lead V1 all the way over at the right-hand side, I would say that these are two fairly distinct looking P waves. So that's where I'm going to start. And if you get your calipers and map that out and say that that's the intrinsic atrial rate, it actually turns out to map out very, very nicely. There's one buried in that QRS complex, but it keeps on going. And then there's a P wave buried in that T wave, causing some deformity of the T wave, and so on. So this is a very nice P wave or atrial rate that maps out. And so that means that this is indeed some type of AV block. Then, as we mentioned, is this Mobus 1 or is this Mobus 2 or is this third degree heart block? How do you know which of those it is? You look at the PR intervals. Mobus 1, as you recall, you'll see a PR interval that gradually increases and then there's a drop. Mobus 2, you'll see a PR interval that stays the same and then there's a drop. In Mobus 3, the PR interval just continually changes. So let's start out here. There's a PR interval that looks a bit long, and then that PR interval is really long, then that's a little bit shorter and maybe about the same size and a little bit longer, then really long, then very short PR interval. So the bottom line is that this PR interval is randomly changing. It's not gradually increasing or staying the same, and that means that this is a complete heart block, and this is a narrow QRS complex escape at a junctional rate. So this is complete heart block with a junctional escape rhythm. All right, so fairly easy rhythm, I think, to get. And you also might see there's a bit of a leftward axis, and there's a little q, big R, little q, big R in 1 in AVL with little r, deep S, little r, deep S. That means that this is a left anterior fascicular block. We've gone over that before. We'll go over it again sometime in the future. All right, so the rhythm here is in this apparent new seizure patient. The patient's got complete heart block with a bradycardia due to a junctional escape rhythm. So easy enough rhythm. But there's some nice take-home points. Once again, just a reminder, the PR interval is the key to distinguishing between the AV blocks whenever you're debating, is this a Mobus 1, is this a Mobus 2, or is this a complete heart block? You look at the PR intervals. And the other point, which is a little bit unrelated to the rhythm analysis, is the point that we kind of started with also. Whenever you've got a patient presenting with a first-time apparent seizure, always check a 12-lead EKG. Look for things that may have caused an arrhythmia, because arrhythmias that hypoperfuse the brain can cause seizures as well, or they may simply cause a patient to have a syncopal episode, and a lot of patients with syncope will have some myoclonic jerks for 5-10 seconds or so, and everybody calls it a seizure. It's not a seizure. So, first-time fall and shake episode, always check a 12-lead EKG. And probably the hallmark is long QT. Long QT syndrome has been misdiagnosed in so many cases as seizure disorder because these patients go into torsade. Let's see if I can draw it nicely. Anyway, torsade, and that hypoperfuses the brain. They fall, they shake, and they get misdiagnosed as having a seizure disorder. So in this particular case, we saw a nice AV block, but whenever you've got a fall and shake patient who hasn't had a confirmed seizure disorder by EEG before, check a 12-lead EKG and consider the possibility that they may have just had a dysrhythmia. And that's exactly what happened in this particular case. So I hope that case was helpful. And my thanks to Dr. Sean Fox and his colleagues down at Carolinas Medical Center for sharing that case. I hope you all are well, and I will talk to you next week. Bye for now.